Dr. John Corboy founded the University of Colorado MS Center, which morphed into the Rocky Mountain Multiple Sclerosis Center at the University of Colorado. He's also the principal investigator in the DISCO-MS clinical trial, which was the largest clinical trial to focus on whether it makes sense for someone over the age of 55 or 60 to discontinue their disease-modifying therapy. Welcome to the ACTRIMS Forum 2025, and welcome back to Real Talk MS.
Thanks, John. I'm happy to be here, and thanks for having me.
As the population ages, we've seen a greater focus on the whole subject of aging in MS. How many people over the age of 55 are living with MS?
A substantial number of people in the United States and around the world are living with multiple sclerosis who are 55 and older. The best data from a large demographic study was published several years ago suggests that of U.S. adults, 46% are 55 and older. And we have, for many years, just thought of MS as a young person's disease, but in reality, there are many people who live long lives and are living longer lives now. The likelihood of dying early from your MS is also diminishing. So people are living older and older. We're diagnosing older people with MS, and just from a numbers point of view, it's almost half of people are 55 and older.
So we're looking at somewhere in the neighborhood of 500,000 people.
Somewhere in the neighborhood of 500,000 people. That same study I mentioned suggested up to 1 million people in the United States have MS. That's the upper end. It could be as low as 700,000, but a substantial number, hundreds of thousands of people could be over the age of 55.
Why are people with MS living longer?
They're living longer, I think, because of a couple things. Number one, we're probably identifying people with relatively modest disease who don't have any substantial impact in terms of disability and dying young with their MS. The second part, of course, is that we've developed effective therapies, and these effective therapies have reduced the likelihood that someone would develop progressive disability, diminish the severity of that progressive disability, and we also have just better ways to treat infections, better ICU care over time. It used to be in the old days that people would, for example, get blood clots in their leg and they would go up to their lungs, so-called blood clots that would go up, and pulmonary embolism, and they would die from that on a routine basis. Now we can recognize that much better, and we don't have that issue. And this is not a trivial issue for our patients, because our patients, many of them are wheelchair bound, and that is potentially a risk factor for developing pulmonary emboli.
How does MS change as people age?
MS changes functionally in many different ways as people age. So pathologically, there are differences in the way the immune system is disrupted as people age. When people are younger, they have these highly inflammatory lesions with white blood cells leaving the periphery of their body, entering into their nervous system, causing these acute relapses. As they age, that becomes much less significant, and there's what's called compartmentalized inflammation, and there's so-called senescence of the immune system as well. And so all of those things result in clinical changes that we see with decreased relapses, and as I noted before, some significant component of people go on to have slow progression of disability, and that is much more prominent as people age. Radiographically, that's seen with people having less new active MRI scan lesions, but they still can have slowly expanding lesions, something recognized more recently. They can also have brain volume loss or shrinkage. When people are young, most of that shrinkage is due to MS. As people age, most of the shrinkage they have is actually due to aging. And so what we can think of as MS in older people, when they have slow progression, it is taking MS and plopping it onto the back of aging. And the two together are not good. And so doing whatever we can before people get old to limit that would be extremely important. So in addition, what we see that's relevant to the DISCO-MS study is that as people age, the benefit of these medicines seems to be more limited. That is, when people have these relapses when they're younger, the medications are very effective. When people have slow progression of disability, the medicines are much less effective. So that's a big change, and that's what was partly what prompted us going in to do the DISCO-MS study.
As you mentioned a moment ago, as we age, things change. We physically change. And as people with MS age, their MS changes too. How challenging is it for a neurologist to sort of determine whether that patient in front of them, are those changes due to their MS, or are they due to the fact that they're simply aging?
The question of what causes the problem as you age, is it MS or something else, is an incredibly important question, because number one, you would treat them very differently, and what you tell the patient will be very different. So The things that are very important over time are things related to vascular disease. So simple things, little white dots on brain scans can be due to MS, or they can be due to vascular disease, or orthopedic problems, spine problems, hip problems, knee problems. Those can absolutely affect your gait. So one of the main things that we have to do as physicians, as people age, is exactly what you alluded to, which is say, what the heck is causing this problem? And is this really something I have to pay attention to differently? You know, especially if somebody has some serious problem like increasing fatigue with shortness of breath. Well, that could be congestive heart failure and not MS. So we really have to become almost more like old-fashioned doctors that took care of a lot of different things, not just the MS. Whereas in young people, they mostly are pretty healthy, and we can focus almost exclusively on the MS. And so it's a mind shift for us when we see an older patient to think about all the other things.
I want to circle back to something you said regarding what you learned in the DISCO MS study about some of the medicines not being as useful to the patient as they were when they were younger. Given that, what's a conversation that that patient should be having with their neurologist after they're celebrating their 60th, 61st birthday?
So the main conversation that we should have with our patients over time, especially as they go over age 60, assuming they've been diagnosed with MS when they're 25 or 30, which is not uncommon, is do I need to continue this therapy? And the decision is always going to be based on the same thing. What are the potential benefits of the medication? What are the potential risks of the medication? What are the potential costs of the medication? And if I go off, how does that change? What does it change with regard to my risk of having new disease activity or worsened disease activity? And how do I balance those risks and benefits out? And if for that individual person, the risks and benefits say, I should really stay on my medication, that's okay, but you should have that discussion so you have the best information available that would then say what's good for you. And everyone is going to be different in that regard. Everyone views risk differently. And so we can't say that there's one thing, one size fits all, and everybody should do the same thing. The reality is that there's, first of all, no one size in general, but it's definitely not going to fit everybody with regard to how they understand risk and what their comfort level is and what their family's comfort level is. I can tell you that one of the main reasons we had difficulty enrolling people into the DISCO MS study was that many people are quite uncomfortable with the idea of going off their medication. But importantly, so are their spouses. And spouses and family members have an oversized influence on people when they make decisions because, like most people, we like to get help making complex decisions, and the spouses and family members play a very large role.
You know, we started our conversation talking about the fact that people with MS are living longer. Have you noticed that people are being diagnosed with MS at a later age than perhaps previously?
Yes, we and others have noted that the age at diagnosis seems to have gone up. So, for example, when I was in training, the standard dictum was that the median age or the average age that people would get diagnosed would be about 30. And there are multiple different studies, including our DISCO MS study, where actually the average age at diagnosis was about 41. That age has sort of moved up over time, and we've also begun to have the discussion about late onset MS. Late onset MS is by definition with first symptoms after age 50. That accounts for about 8% or so of people. And then there's very late onset MS over age 60, and that accounts for not quite 1% of people. So this concept that people are all 30 years old when they get diagnosed is not true, and that number has moved up over time for sure. And we see it, and we saw it in the DISCO data, and we've seen it in other recent studies as well.
Well, Dr. John Corboy, I want to thank you for all you do to improve the lives of everyone living with MS, and thanks so much for talking with me.
Thanks for having me, John. It's always a pleasure to see you.